Firstly, thank you for accepting the invitation, and I'm really excited to be speaking to you. As I mentioned, I've completed my MBBS from India, and I'm a junior doctor over here. And I was, but I mean, ever since I started medical school, I was always interested in philosophy and kind of, larger philosophical questions, more around existential kind of questions. But again, I mean, philosophy in general. Uh, Initially, I had some trouble, adjusting to medicine. I couldn't really find myself comfortable over here because of the lack of philosophy or the lack of this, humanities connection that we have. And I suppose it's not the case like that everywhere. It is more to do with where I'm studying medicine in my university and in India in particular. Because I'm sure, I mean, I know that, people have these kind of, medical humanities and, philosophy and anthropology of medicine, those are part of their medical courses, right?
Right. So is this kind of dual study in India common, where you study medicine and study, say, anthropology of medicine or philosophy of medicine, something like that?
Not at all, actually. I mean, we don't have anything like that at the present moment. I mean, our medical studies are just,
Okay.
more. I mean, we just study the core subjects of medicine, science. So, I mean, this kind of lack or this is what I was trying to overcome or compensate for in my own readings, because I felt that this thing was lacking over there. Yeah.
At least in North America and in the United Kingdom, it's quite common for people to study medicine, get a medical degree, but also spend a couple of years studying philosophy of medicine. Sometimes that develops into kind of dual career. So I certainly know several physicians who also contribute to professional scholarship in philosophy of medicine.
Yeah, certainly. I mean, I've seen some people pursue. I think a lot of them do medical ethics on the side. I mean, they have a career in that.
That's true.
Right?
That medical ethics in particular, has been a domain in which many medical practitioners get involved, and I think that's in part just a result of like the practical realities of life in, say, a clinical setting. It's also been the case for philosophy of medicine more broadly, although in philosophy of medicine more broadly, the contributors tend to be trained philosophers.
I mean, these kind of people. For example, I was attending a program by a person from Johns Hopkins University, Dr. Jeremy Sugarman, who's done an MD, and he's also he works in medical ethics as well. So I mean, those kind of presentations were more on the verging around, fraud in medicine, outright fraud in medicine. Which is something I noticed that you don't I mean, explicitly talk about that much. I mean, for example, you highlight in your book more on the the methodological problems that medical research has.
Yeah, right. That's exactly right. I mean, what I wanted to do in that book and in some related articles is not to pin the blame on just outright fraud. In part because I'm not so sure exactly how rampant outright fraud is in medical research. But also, I mean, my hunch, and I think it's a well-informed hunch, is that what is really widespread are the much more subtle and in many cases unintentional ways in which medical research can be bent. I use this term malleable in the book. So I argue that many research methods in medicine are malleable, and that doesn't require outright fraud, like the existence of the malleability itself or the exploitation of the malleability of the methods. Doesn't require outright fraud. It just requires there being a bunch of decisions made by a bunch of sort of distributed scientists. So yeah, which all that's to say, of course, fraud happens. There are many very wild accounts of fraudulent scientific and medical research, and that's of course a problem. There's a case to be made that, so one of the most common forms of bias in medical research is publication bias. And one thing that I hint at in the book is that publication bias arguably should be considered a form of fraud. At least when we're speaking about research on clinical interventions, like testing some new pharmaceutical, the withholding of data from the public record is really a matter of profound consequences, and could and perhaps ought to be considered fraud.
Yeah, certainly. I mean, I remember the first time I learned about that, that a lot of research also goes unpublished. I mean, it really felt like something truly scandalous. I mean, how can this happen? I mean, how can they get away with this? I mean, because how would you say that? I mean, I've heard of these kind of movements and these kind of campaigns that are happening to, for example, the all trials movement, right? That all trials need to be pre-registered and all these kind of things. I mean, how because these have been happening since some time now. I mean, how much do you think these are impacting or creating some change on these issues?
I think these kinds of campaigns are having some positive impact, and I think when one takes a kind of broad look at the quality of medical research over the last several decades, I think a case could be made that the methodological quality is getting better and better, in part because of these kinds of campaigns. And certainly the really big issues like publication bias have been now so widely discussed that these all trial campaigns have been quite prominent, and I think have had some impact. There are many cases in which pharmaceutical companies were for some time withholding data, and then were required to hand over the data to, say, academic analysts or courts. And in some cases, for example, there's a big trial implicating GlaxoSmithKline, and GlaxoSmithKline, the big pharmaceutical company, was required to then make a database for all of their trial data, and that trial data was then accessible by independent academic analysts, and that's of course a good thing. There's still much more that can be done on that sort of issue. So, for example, just getting access to the data is one thing, but if the data is already infused with methodological problems, then we're still stuck with dealing with mediocre data or unreliable data. So many of our colleagues in medicine and philosophy of medicine have been arguing that there should be a system-wide setup such that the institutions that are testing medical interventions aren't the same institutions that stand to gain financial profit from the manufacturing and selling of those interventions. So in other words, the production and the testing of interventions should be independent. I wrote an article with a few colleagues in which we argued this very point. We don't have that kind of independence yet. But as you say, we do have these campaigns like the All Trials campaign, where the key aim is to make data from clinical trials more publicly available.
Yeah. And that point about keeping those who are testing and those who are judging, I mean, that separation. I think Dr. David Graham also, I mean, made the same point, right, about the FDA.
Oh, so you're speaking about the epidemiologist David Graham at the FDA.
Yeah, David Graham. Yeah.
I mean, he may have made that point. I mean, he's made lots of very important points that I think are right, and for whatever reason are controversial. I'm not sure if he's made that particular point, but I wouldn't be surprised if he has. Yeah.
Just apologizing for not asking about this earlier. I mean, how are you doing? I mean, amidst the whole pandemic. Yeah.
Oh, it's kind of you to ask. I mean, the pandemic has been just so profoundly serious in everyone's lives, and everyone's lives have been affected in a variety of ways. Some people's lives have been affected in very kind of trivial ways, and other people's lives have been just really affected in the deepest and most profound ways possible. And thankfully, I think things are fine here with me. Thanks for asking. Yeah. I haven't been keeping such close track on the situation in India, but I understand that the COVID situation in India is really quite a crisis now. Is that right?
Yeah. And a lot of the deaths are also, I mean, even the official figures are not truly reliable in many ways, because they are, I mean, underestimated. A lot of the deaths happening because of COVID are not being taken into account. For example, only, I mean, if a person has comorbidities and dies, so it isn't prescribed to COVID. I mean, it's considered as an independent death. And if a person also wasn't tested positive but might have had the symptoms, so that kind of person is also not considered a part of COVID-related deaths. I mean, it's hugely underestimated.
It's interesting. So right. I mean, I've heard arguments about different jurisdictions, counting deaths in different ways, and so some people are arguing that in some jurisdictions the mortality attribution is overestimating the causal influence of COVID on mortality. So, for example, if somebody has COVID and then dies in a car accident, they're being considered a COVID case, a COVID death. Unfortunately, different political jurisdictions are counting in wildly different ways. So where would you like this interview to go?
Okay, so I'm thinking of discussing, of course, medical nihilism, with you, a few things about that. And I mean, of course, what you call medical nihilism, that is the negative way of putting it. The positive way would be to say gentle medicine, as you say at the end of the book. Right? It's the same thing. So we could talk about that, and I'd like to talk a little bit about your new book you're working on, the sexual sciences. I'm not sure exactly what we could talk about that, and philosophy of medicine in general as a field, and certain questions about epidemiology and population health, preventive health, because I mean this has been problematized by some writers. For example, I was recently reading this book by James Lefano. Are you aware of him?
No.
Dr. James Lefano. So he's been a GP for a long time in the UK, and he's written a book called which won some prize. It's called the Rise and Fall of Modern Medicine. This book came out earlier. Now he's recently got this book out called Too Many Pills, about basically overdiagnosis and overtreatment. And he has some, I mean, he takes issue with the whole kind of preventive medicine kind of approach that came with, Jeffrey Rose and those kind of people. So we could discuss a little bit about that. And and of course, I mean, I'm interested to know about polypharmacy is an issue. And you, at the end of the book, you actually say that, we need more kind of evidence on deprescribing, which we don't really have. So we could, I mean, I'm interested to know more about that. these are, it's all over the place, as you can see. So we can just take it
Sure.
however you want. Yeah.
Well, we can take it however you want. You're the host of the discussion, so
Right.
I'm happy to speak about any of those topics.
Okay. All right. So I'd like to say about how I first encountered your work. So this was in 2019, middle 2019, when I was actually preparing for a bioethics conference in India that was happening, and I was looking at publication bias, uh, and I was, I encountered I read, all these kind of people, Ben Goldacre, for example, he talks about that, other people, and there are all these. As you were also mentioning in one of your lectures, that you were also coming across in all of these kind of people who are within the healthcare profession, or within the field, and who are critical of medicine. All this kind of critical genre was coming out, and your basic attempt at writing this book, or doing this research, was to see whether it stands to scrutiny, or whether it can, how philosophically strong are those arguments, right? I guess that was your basic motivation behind it. And that was also the same feeling by which I took up your book, because I was coming across all of these arguments, and I felt that these arguments, there was some argument there was some rhetoric as well. Definitely, and there was some dramatic kind of presentation of those things and all that. So I really wanted to get at the core, and see how strong is the argument itself, and that's where I really found your work very helpful, because it looks at it with philosophical rigor and precision. And, I've seen that in your in some of your lectures, you have this slide of a list of of some such books that have come out, like for example David
Sure.
Healy's Farmageddon, and Marcia
Yeah.
Angel, and all those things. So you don't. Of course, your argument is philosophical, and you're dealing with the argument. You're not dealing with any particular person, or in any particular book, or you're not commenting on that specifically. But I'd like to ask you this question. How would you? Would you say, or could you give any specific examples of where you think these people who are being critical of medicine, where you can be critical of them, for example? Where they're not being philosophically rigorous enough, for example. Could you?
Sure. Yeah. Sure. So, I should say that in that genre, of course, I was very impressed by that genre, and I learned a lot from books by people like Ben Goldacre, Marcia Angel, David Healy, but as you say, those books tend to be very about very particular kinds of issues. So, for example, Ben Goldacre's book on medicine, he is, in some sense, he's making a general point about publication bias, and raising awareness about the importance of publication bias. And so it's a general issue. And he makes the point by appealing to particular examples. And examples are good, and I try to draw on some of those examples in my own book. But because I am a philosopher, I try to assess the kind of general structure of the argument, and to ask what more general lessons can we learn here that go beyond just a worry about publication bias, for example. And so that's not a criticism of those books by people like Marcia Angel or Ben Goldacre. It's just that their interests are slightly more, in some sense, specific than my interest.
Yeah, and they're also written for a general audience, so that's also there.
Yeah, exactly. Yeah, so there's a kind of style of writing in books that are written by physicians for a general audience, and the kind of genre often appeals to very particular cases. Like, I had this patient walk into my clinic, I prescribed the patient blah blah blah, and then 3 weeks later the patient was complaining to me about blah blah blah. And it's very people respond to these very anecdotal cases. Yeah. For whatever reason, people find anecdotes very persuasive.
Yeah.
What's ironic to me, actually, is exactly the role of anecdote. So in evidence-based medicine and in like philosophical thinking about scientific methodology, we have rightly become suspicious of reasoning from anecdotes, because we have good reasons that suggest that reasoning from anecdotes, at least when we're reasoning from anecdotes to conclusions about general causal relationships, like this drug does blah, 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 reasoning from anecdotes is very unreliable. So that's a kind of general philosophical point. And then one thing that can be a little bit frustrating is just how anecdote rich some of these books are, because it's a bit hard to know like what we're supposed to conclude from a collection of anecdotes.
I mean, in the book that I was talking about recently, which I read by James Lifano, which it is also, I mean, again, I mean, when I think about it now, it's also like presented as anecdotes, basically. It's stories of people, of particular cases. I mean, of course, I mean, there's also data behind that, but anecdotes are a major part of those books. Yeah, I mean, this is an interesting question because anecdotes are also in some way, I mean, a way of expressing your own clinical judgment, I suppose, right? And this is there's this question of where does clinical judgment come in? I mean, with all the evidence and the statistical kind of evidence that you have, and the what is the place of clinical judgment? Because I suppose that is something which cannot necessarily be always be translated into any figure, because it is more of an intuition or a hunch that you have.
To your point about clinical intuition and judgment with respect to anecdotes, and it's true that, of course, like clinical reasoning is often like anecdote based, and a collection of many anecdotes over one's career is part of what constitutes expertise, and that's important. Of course, it's important. One of the key issues in medical research and then in the development of scientific methods that are meant to undergird that medical research is causal inference. Like in medicine and in many areas of life, we really want to know, like, if we do this, what's going to happen? If we give this pill, what's going to happen? Or if in general we give this kind of pill to these kinds of people, what will the effects be? And as you know, the main method that's been developed to test those kinds of causal hypotheses is the randomized control trial, and sometimes meta-analyses of the randomized control trial. And that's a really sophisticated method with all sorts of checks and balances on one's reasoning. And it's like orders of magnitude more careful and more sophisticated than merely reasoning from anecdotes. It's not perfect, and many critics of evidence-based medicine and medical research, including myself, have pointed out all sorts of like fine-grained problems with randomized control trials. So they're not perfect. They very often lead us astray, but arguably they're much more reliable than just reasoning from a collection of anecdotes. So if the question at hand is a question about causal inference, like what effects does this kind of pill have, then carefully controlled methods like the randomized control trial are just vastly superior to first-person anecdote, where the person relaying the anecdote is either like the patient themselves who's taking the pill, or the physician who made the prescription is monitoring the patient's response.
We're talking about medical nihilism, but what I'm also, I mean, I really like the phrasing medical nihilism. Of course, what you mean by nihilism is something very specific, and you don't generally mean, I mean, your basic idea is that we need to have less confidence than we presently have in specifically pharmaceutical kind of interventions, medical interventions. And I mean, from my own experience in India, I've found that people over here are because I mean allopathic medicine, or this Western medicine is basically seen as something that is imported from I mean, it's not something that people always necessarily accept. I mean, people don't accept it in many, I mean, especially, people from a certain class of society. We don't have much acceptance for those kind of things over here because there are so many alternative medicines that, I mean, Ayurveda and, Greek medicine or Unani medicine as it's called over here.
Mhm.
And um, so but I suppose with these kind of attitudes, they're not principled attitudes towards medicine. They are more like you could say prejudices, or because I mean these aren't reasoned positions about rejecting medicine or not accepting medicine. So I suppose that could be
Well,
called
it's,
medical absurdism instead
yeah,
of medical bias.
maybe. Yeah, I mean, I get where you're coming from, and I find the sort of range of questions that you're raising here like really deep and hard and interesting. So, I mean, one question is that attitude that you're making reference to principled or not? I mean, in some sense, one could say, well, it is principled, right? Because the choice to use one kind of system of medicine over another could be based on one's kind of background folk cosmology, for example. Like if you have this set of particular theological or metaphysical beliefs, then it might follow, in fact, that this kind of medicine is the right medicine for you, and that's a principled set of reasons. Now, it might just be that you and I don't share those theological or metaphysical beliefs. But if we did share them, then that kind of
Yeah.
medicine might in fact seem kind of principled, right? And this raises another relevant issue, which is one of kind of colonialism and postcolonialism. So, as you know, there's a kind of trend in the academic circles to challenge the kind of colonial and post-colonial heritage that many of our intellectual and institutional practices have inherited. And some people say medicine too should be questioned in this kind of post-colonial, using this kind of post-colonial attitude. And what that looks like exactly is well, that could mean different things to different people. But one thing it seems to mean for many people is the promotion of local, like folk medical traditions, and I'm not sure there's anything that's like very sort of glib and easy that can be said about that. So, of course, as a coming from this kind of Western scientific tradition where I've inherited, the kind of modern scientific metaphysical view that motivates in me this kind of like scientific approach to medicine that it's not implemented perfectly in Western medicine, but there's at least an attempt to reason physically and biochemically about pathophysiology and interventions on that pathophysiology, and that I think is the right way to go. And I don't want to be a cultural relativist, so I don't want to say things like, well, like I have my metaphysical views and other people have their metaphysical views, and we can all just kind of get along, and there's no kind of second order position with which one can judge, my metaphysical views versus those people's metaphysical views. I don't want to be a cultural relativist. But I also want to be like, sensitive to local folk traditions, and not be kind of, culturally arrogant, so to speak. The arguments in medical nihilism, I think, render this sort of set of issues a little bit in a sort of complicated way, because insofar as those arguments are compelling, it suggests that our version of medicine is not nearly as good as we often make it out to be. And if that's the case, then what we might call medical colonialism has a lot less going for it. And so, there's always a practical question at stake, like, well, what should we do? Or what should this particular person in this particular community do when they have such and such kind of ailment? Should they go to their... Yeah, so comparing like folk traditions of medicine to Western traditions of medicine, insofar as medical nihilism is a compelling argument, then folk traditions don't look quite as like impoverished as, or at least relative to Western medicine, they don't look quite as impoverished as a kind of mainstream medical person might think. And I think there's a second thing that can be said about this as well, namely, for many diseases that Western medicine is trying to treat, our interventions are pretty harmful and minimally beneficial. So here I think of a lot of our treatments for psychiatric diseases, for example. And arguably, so we have really good empirical reasons to think that some psychiatric diseases like depression are very placebo responsive. The vast majority of the patients' improvements on antidepressants are a result of the placebo effect. That's for sure. And if that's the case, then we might as well try to harness the placebo effect while not eliciting toxic side effects. And arguably, that's part of what folk medicine can do well, is to harness placebo expectation type effects without eliciting harmful toxic side effects. Yeah. So this whole range of cluster of issues when you mention traditional medical practices in comparison to Western medical practices, and I don't want to give the wrong impression that I think that there's something like causally efficacious about basically any of the alternative medical modalities, but in some sense that's tangential to the point of whether or not they can do some good in some contexts.
Yeah. So, this is, I'm really interested to talk soon about psychiatry more with you. But while we're on this topic, I suppose what we're saying is basically these are like different paradigms, and within those paradigms, they're taking a principled approach. And one more thing, the impression that I got from reading medical nihilism was that these kind of arguments would in fact be more forcefully applied to something like homeopathy, or for example Ayurvedic.
Sure.
Because so although you are acknowledging that there's this, there's a lot of benefit or potential benefit in these kind of alternative remedies, but that would be because of the placebo more often than not.
That would be, I think we have really good reasons to think that, yeah.
Yeah.
I think we have very, very good reasons to think that there's no causally efficacious beneficial effect of most alternative medical modalities other than the expectation effects that are constitutive of the placebo effect. But that I think is clear, but that's not something to be very dismissive about either, because that can be very important. mainstream medicine has very few cures. um,
Yeah.
but they have some cures for some kinds of ailments, and the placebo effect can also be uh, a tool in our our toolkit for providing some care to people.
Yeah. And I mean, before moving on, I mean, another interesting term, I mean, like we spoke about medical nihilism, and I was saying that there could be something known as medical absurdism. I mean, not in this idea that everyone who's participating in or partaking of traditional medicine is necessarily doing something which is not a principled position. I mean, I'm not saying that, but what I'm saying is, uh, I mean, I see this in because uh, I suppose we don't have pure paradigms existing anywhere. I mean, it's all intermixed. I mean, the reality is that people take from multiple traditions at the same time. And for example, I mean, in our situation, we are in a country where their traditional modes of medicine are something else, but the predominant mode of medicine that is used is the Western mode. What I feel is that people, even those doctors who are doing Western medicine in India, even really senior doctors, are also, they retain this kind of attitude about which again seems like an attitude and less like a philosophical position that they're taking. Uh, and in that sense, I was saying that when people are I mean, because you also mentioned this in another lecture that the kind of Trump effect or the Trump narrative of medicine, of just questioning authority, not respecting expertise. That is another kind of extreme or uh,
Yeah.
and
That's exactly right. So the expertise doubting is another very important dimension to this, which needs to be treated cautiously.
yeah,
Because as this lecture that you're referring to, in that lecture, I was trying to make the point that a very large and dangerous part of at least Western society, I'm not sure if this is true in India as well, but certainly in America, and perhaps to a lesser degree in parts of Europe, there is an anti-scientific, anti-intellectual movement or aspect of our culture. And this is seen in many different ways. Um, this kind of the widespread concern about childhood vaccines or denying the existence of climate change. Um, One sees this kind of anti-intellectualism and anti-expertise in many different ways. And one worry that I've had for myself, and one might have about the book, is that it's contributing to this kind of anti-expertise sentiment. And I certainly that's not the case. I mean, in some sense, what I'm arguing for in the book is just that faith and expertise in medicine has been kind of misplaced. And it needs to be a different kind of expertise, which is more prominent in medical thinking. But it's certainly not anti-intellectual or anti-expertise, and that's it. But for an average person, when they have some kind of disease and they need to decide what they're going to do about it, they need to decide who they're going to trust. Are they going to trust this doctor or that doctor or this folk healer? And at that moment, there might actually be good grounds for the person to not trust such and such doctor, not because of that particular person, but because of the framework within which that physician's working.
these are the all as it were differential diagnoses that you can have. There's medical nihilism on the one side, there's medical absurdism, and there could be something as medical anarchism. Anything goes, and for example, the kind of people who are influenced by or the work that's influenced by Paul Feyerabend,
Sure.
epistemic anarchism, those kind of. So, I mean,
Yeah.
your work is clearly distinct from all of these kind of approaches, and it is, in fact, what you're saying is it is not scientific enough. It needs to be more scientific, more rigorous, and more right.
Yeah, that's exactly right. Yeah. So that was my guiding principle in the book, is to argue that medicine needs to be more scientific, not less scientific, and certainly not more like anarchic in that sort of Feyerabedian sense that sort of anything goes. No, it's it's that it's certainly not that anything goes. It's that we need better grounded inferences about diseases and interventions on those diseases, and that requires more science, not less science. Yeah.
I suppose, I mean, why, I mean, what you feel also when you say that, this could be potentially taken to support those kind of movements, those kind of anti-science movements. It might be because of the kind of provocative term that you've made for it, medical nihilism. I mean, for example, when you call it gentle medicine, it doesn't seem so provocative. It seems like something people might agree more easily on.
Yeah, that's right. Yeah, I mean, in some sense, that term medical nihilism, it's just a term to kind of bring together as an umbrella argument, like all the particular sub-arguments. And some people respond well to that title. Other people respond more to this term gentle medicine. And the way I conceive of it is they're not two different terms for the same thing, but medical nihilism is this kind of umbrella term to describe all of the skeptical arguments they're based on problems with medical research and problems with the very small effect sizes of the interventions that we have typically have at our disposal, problems with bias and fraud in medical research. And gentle medicine is supposed to be the term that's the kind of umbrella term for our response to medical nihilism. So insofar as medical nihilism is compelling, then gentle medicine, which is like this cluster of particular ideas about different aspects of medicine, is supposed to be the response. Like gentle medicine, it's of course about how clinical medicine should change. So the idea is like, well, we should have an interventionist in the clinic, but it's also about research, like the kinds of hypotheses that we want more evidence for, given all of these I described in the earlier parts of the book. So, if our pharmaceuticals aren't as good as we think they are, then maybe we need better evidence on diet, exercise, and so on. And then one thing that you mentioned at the start of our discussion was the drug discontinuation programs. So, mountain of evidence for the apparent beneficial effects of medical interventions when we put a patient on that, when we give that intervention to the patient. But we have much less evidence in terms of quantity and in terms of quality regarding what it's like to systematically take people off interventions. And since part of the position of gentle medicine is that we should be taking many people off many of their medications, we shouldn't be doing it blindly. We shouldn't be doing that ignorantly. We should be doing that with as much evidence as we can get. And so part of gentle medicine is the call for studying drug discontinuation.
Yeah. So, I mean, because I've read your book. I mean, I'm not sure to what extent we should really get into the arguments over there. Should we be discussing? I mean, for example, we could just mention them about the some of the major problems include, publication bias, p-hacking, and allocation bias, and I mean the dearth of magic bullets. I mean, and you really connect all these things into a neat mathematical formula through Bayes' theorem, and by ascribing probability values to these kind of various factors.
Yeah.
Yeah.
Yeah, the Bayes theorem formalization is just a way to bring these like very different arguments together into one big argument. I call it the master argument. But the master argument has three basic premises. One is about the methodology of medical research. We've been talking a little bit about this, just the fact that medical research is shot through with biases. The key premise number one. Key premise number two is empirical. It's about the widespread small effect sizes. So when we test the vast majority of interventions using our best methods, like randomized control trials or meta-analyses, it turns out that the most widely used interventions on average tend to have very tiny effect sizes. So that's kind of key premise number two. And key premise number three is thinking more physiologically about diseases and the interventions. And the argument is that we have, for any particular new intervention, we have very good reasons to think that it's not going to be a so-called magic bullet. It's not going to be like penicillin for a bacterial infection. We have very few drugs like penicillin, what I call magic bullets. And so those are the three key premises, right? Few magic bullets, many effect sizes, biased methods. And of course, it takes like 2 or 3 chapters for each of those premises, like to kind of like fully substantiate those three premises. Take them all together, then you ask, right, so suppose that we read in the newspaper about some new drug which is supposed to do blah, blah, blah. How enthusiastic should we be about that drug? How excited should we be about that drug? How much confidence should we have in that drug? And well, once we take those three premises of the master argument, even if we read a report that there's this new drug that does blah, 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 we should anyways be skeptical. That's the kind of the big picture argument of medical nihilism.
Yeah. And of course, another important, factor is also what I suppose it's known as type 1 error, where basically, a drug might prove effective in an experimental setting, but it might not be so effective in the real world, which is also what you highlight. Among a lot of things, and through all these kind of, looking at it from all these parameters, because what I'm interested to know is, because medicine is the name of all of these different specializations or different subfields within the field of medicine. What would you say? Which field fares better as compared to these parameters, and which field fares worse? For example, psychiatry seems like very problematic from all of these parameters, but maybe accidents and emergency or emergency medicine seems less problematic from those parameters. Could you say some more about that?
Yeah, I think that's exactly right. So, right, with those key premises in mind, then we can ask. One thing to note is, as described so far, it's about medicine. Like it's a huge domain, and as you said, medicine is comprised of particular subspecialties, and moreover, in any given subspecialty, we could apply that reasoning not just to the subspecialty, but to like particular diseases or particular interventions, right? And that is, I think, the right way to go ultimately. So to your question, I think it's exactly right that these premises apply more to some subspecialties over others. Psychiatry is an example of a subdiscipline in which we have basically zero magic bullets, absolutely tiny effect sizes for the interventions, all sorts of biased methods, including especially publication bias, but not just publication bias, many biases in the very best methods like randomized control trials. And so psychiatry is especially shot through with the reasons that motivate medical nihilism. What's been interesting to me is, so I think a case could be made that, say, surgery, for example, or you mentioned emergency medicine, is less affected by these operations. So like one example that I sometimes give is if you're in a car accident and you're just like bleeding out of an artery, then merely staunching the blood flow is a magic bullet for that ailment. Right? You're just directly modulating the causal basis of this big threat to your health. That's so we know it can save lives. And so it looks like, okay, there's a magic bullet. Another consideration is the widespread kind of exploitation of biases and methods. So one of the motivations for the exploitation of biased methods is the financial profit that can be had for getting some intervention to look effective. But that financial profit, that profit is different in different medical domains. So in, say, internal medicine or psychiatry, if you can sell a pill, you can make a lot of money, because selling a pill is a little bit like selling MP3 files. Like once you have the intellectual property, actual like production of the product is very cheap, and so if you can sell just this cheaply made thing for a lot of money, you can then make a lot of money, sell that product to potentially millions and millions and millions of people. And you don't always need like a medical expert to be like delivering the intervention on a kind of daily basis or case by case basis. Whereas with surgery, there's some different kind of profit incentive in surgery. Surgeons, at least in the Western world, make a lot of money, but there's less of a situation in which you've got this kind of large, wide scale, like widespread market distribution of a piece of, you know, intellectual property that's making some big company a lot of money. So the financial incentives are just different in surgery than they are in, say, psychiatry. And I think that mitigates, to some degree at least, this worry about exploiting biased methods. But I don't think it totally eliminates the worry about biased methods. And in fact, I've received correspondence from surgeons who say to me, like, yeah, all the arguments that you made to medical nihilism would apply to my own specialty of orthopedic surgery, say. That's, in some sense, that's kind of surprised me to hear, you know, senior orthopedic surgeons saying my own craft is as bad as you say it is in psychiatry. But
the profit dimension is very interesting that you're mentioning. I remember reading at a point you also mentioned how I mean, when you compare antibiotics with, I mean, because antibiotics are those kind of medicines which, you know, people take for a few days and they stop taking them. But, you know, if you compare it with some kind of, with other drugs which people take on a longer term, or, you know, perhaps for lifelong, you know, for example, like drugs for heart disease, or, you know, drugs like, for example, statins. I mean, we can really discuss more about statins, and you know, again, for a lot of these psychiatric ailments as well, you know, depression and bipolar, people tend not to stop taking those drugs. So I guess that was a really interesting point, that, you know, the sheer fact, you know, that this drug is potentially, I mean, you're potentially getting a lifelong consumer with that drug. I mean, that also affects a lot of the bias. You know?
Yeah. This is, of course, not just me saying this, but a lot of people are saying this. And in fact, there are some very compelling journalistic exposés of pharmaceutical companies in which pharmaceutical companies say this, that proper cures in medicine are not good business. Because if you cure someone, then you're no longer selling them your product. So cures aren't financially profitable for companies. Some people claim that this is the reason why there aren't so many new antibiotics in the research pipeline, because antibiotics are, as far as they're an effective antibiotic, they are a cure for the disease which they're being used to treat. And moreover, because we have this like threat of antibiotic resistant organisms, it's often the case that new antibiotics are reserved for like really bad cases of antibiotic resistant organisms, precisely because we don't want to develop resistance to new antibiotics. We want to use new antibiotics in the future. And so if you're a pharmaceutical company, you know all of that. You know, A, if you have an effective antibiotic, it's only going to be used for like a week or two. And B, if you have a new antibiotic which is effective, it's not going to be used by a number of patients because it's going to be, kept in a cellar somewhere until the next plague of antibiotic resistant organisms. And so that's not much of an incentive to develop a new antibiotic, which is ironic because antibiotics are magic bullets, right? So we have this class of drugs, which is exactly what medicine should be striving to achieve. And there's not so much incentive to develop such drugs.
Psychiatry is an interesting topic to discuss. I must say that I am also interested in pursuing psychiatry in my further training. But again, because of these factors, and precisely because psychiatry becomes so problematic from a with all the industry involvement and all the kind of the low efficacy of drugs over there. These factors make me hesitant to really pursue psychiatry in that sense. What would you say about psychiatry in general? Is there any? Because reading your book too, and as we were discussing, right now that psychiatry is one of the most problematic disciplines. From these parameters. So, is there any scope or any hope for a better psychiatry or
Sure. I think it just depends on the treatment modalities that one uses. Psychiatrists do a lot of different kinds of things, and I find it likely that, for example, just to take one example, that like suburban depression, I like to call it, like most cases of depression, there's not going to be a new intervention that makes treating such cases very successful or rewarding. But for example, very severe cases of psychosis, of course, we don't have cures for severe cases of psychosis, but at the very least, when medicine tries to help, they can mitigate a lot of suffering, both in that individual and in the surrounding individual's life. And psychiatry is on the forefront of helping such patients. So, I certainly hope that nothing in the book it would be like demotivating for a physician in training, for example. Although I do have in Cambridge saying something like that, they'll say, I wanted to go to study medicine, but then I read your book and now I'm not so sure. And I certainly hope that I don't have that impact, because medicine is a very rewarding career, and there are all sorts of ways in which a physician can do lots of good, including in psychiatry. And in some sense, having exactly who is self-critical or critical of one's own discipline is exactly what psychiatry needs. And so, if anything, I would say, yeah, go for it. When I was in my first teaching job in the University of Utah, I had one psychiatrist was sitting in on my graduate philosophy of medicine, and I was shadowing the clinical work of another psychiatrist. He was working in like a intensive psychiatric ward, and so we saw the kind of the worst kinds of psychiatric
Mm.
patients that one can imagine. And it's clear to me that he was having a big impact on their lives and the lives of their families, their communities. What especially impressed me about what he said about his work in particular was he viewed part of what his responsibility was to get patients off of drugs. You know, a psychotic patient coming in from the community is often on like multiple pharmaceutical, like prescription drugs and multiple recreational drugs. And especially in the American context, they're only going to be in the clinic for like a very finite period of time because there are these financial constraints on how long the patient can be in the hospital. And so his job, part of the job was, okay, I'm going to have this patient for 2 or 3 days. They're on such and such prescription drugs, such and such recreational drugs. How do I get them off the most number of drugs while keeping them safe?
Yeah.
That impressed me.
Yeah, certainly. Um, I guess one concern is also that, I mean, David Healy really gives a very pessimistic view of a career in psychiatry, despite being a prominent psychiatrist himself.
Yeah.
Because I mean, you get the impression that I mean, even if you independently get a sense of what kind of intervention is right in this scenario, or whether even if you know that you're not you ought not to be giving certain drugs, but you also have the pressure to stick to guidelines, of course. I mean, if you deviate from that, I mean, your career could be in crisis. I mean, you could be sued or you could be fired.
Yeah.
So is there still scope? I mean, despite these things, I mean, because I mean, you have to stick to guidelines at the end of the day. And so if you are in a profession which is inherently, I mean, at least at this point, it seems to be in many situations, in some situations it seems really effective. For example, I mean, my impression is that in more severe kind of psychiatric cases it is more effective, but the concern is that whether I am doing more harm than good, I mean, by going in this profession, I mean, by choosing this discipline.
Yeah. So well, I think you could do more harm than good, but then it might also be the case that one would have to resist to intervene, and so and that can be hard for a profession which is just entirely centered around intervening. So you do more good than harm without doing all that much good. Or at least in many cases, you might end up thinking like, well, the best I can do is just nothing, or talk the patient out of the drug that they're asking for. And as you say, a lot of clinical practice is constrained, right? So it's not like physicians can just decide, like, I'm not intervening in this class of cases. But there's a wide range of cases in which physicians exercise a great degree of judgment about whether or not they're going to prescribe this or prescribe that, or go with this dose or go with that dose, or not prescribe anything. And so within that range of possible judgment, one could, I think, doing more good than harm, but one might also just have to just understand that if they'll kind of rein in the extent to which they're intervening.
Yeah.
But that can be very valuable. I mean, for example, one kind of, just to go back to using anecdotes, so I'll appeal to one of my own anecdotes. When I was a student, I tore the anterior cruciate ligament of my left knee, and it's like a common sports injury, and it was a full tear. And there's standard procedure for it. You like reconstruct the ligament by using tissue from either the hamstring or the patellar tendon. And my treating physician called himself a non-interventionist. And at the time, I didn't really understand what that means. But he told me about some trials that showed that for patients that were getting like some physiotherapy and stretching and exercise, that their endpoints were similar to patients who had the surgical reconstruction. so what the physician did for me was just basically like have a conversation and directed me on a path of therapy that I then pursued. And that was really good for me. Physician for his action, and he did more good than harm. But he didn't prescribe anything. Yeah.
Of course, I mean, speaking with psychiatry, people also, I mean, how much do you think the biological model is predominant in psychiatry? I mean, for example, is there a trend that people, psychiatrists are doing less and less of psychotherapy in those kind of psychological? I mean, is that because I mean, the pharmaceutical involvement tends to bias, pharmaceutical intervention. So
Yeah.
is psychiatry that kind of a discipline where you do not necessarily have to think like other medical disciplines about pharmaceuticals? And is that
This is my impression that psychiatrists largely, conceiving of diseases and deploying treatment modalities which are on the just like the strictly biological model. But there's a lot that can be said about this. So,
yeah.
I mean, from a metaphysical, we have good reason to think that psychiatric diseases just are biological diseases. And so, in some sense, we ought to be pursuing the biological model for psychiatric diseases. But on the other hand, we're so far from having a well-grounded understanding of psychiatric diseases, so that the deployment of the biological model, in some sense, one could say, just looks premature, immature approach to treating psychiatric illnesses.
Yeah. We'll wrap this up in the next 10 minutes, if that's fine with you. Just two more questions that I'd like to ask. So, I mean, all of this leads us to the question that, I mean, for you write the book for people who are engaged in research and who are dealing with those questions. I mean, you don't write it for a lay public, or again, I mean, you also mentioned that this is something that requires expertise, and it is not something accessible to everyone. I mean, there are two questions here. I mean, if medical research is, I mean, like all science, I mean, it requires expertise. What is the meaning of patient autonomy when the patient is, I mean, that kind of research or that kind of expertise remains inaccessible to the patient? I mean, it becomes such a sophisticated, enterprise. I mean, for example, I mean, there have been people, I mean, there have been attempts at trying to demystify what happens in medical research for the lay audience, to encourage their autonomy, to help in those areas. But so this becomes a question. Another one is that, for a person who is a junior doctor like me, for example, where, I mean, and for, I mean, any doctor who is seeing a large number of patients a day, and I mean, he's busy in clinical life. I mean, guidelines are a good shortcut for us because I mean, we can't, I mean, afford to spend that much time on sifting through the research and doing that. So, I mean, again, guidelines are also something that you raise questions about. So, what alternative would you say there is for us? I mean, could you recommend some resources in these regards? I mean, perhaps any guidelines on the parameters of gentle medicine?
Yeah, sure. So I think, yeah, these two questions are closely related. I think that there's one answer to both of these questions. So if the production of medical research were improved, and then if the systematic assessment of that research in the production of guidelines were improved, then that would help both patient autonomy and the busy physician. So patients would have more to rely on. And physicians could, use guidelines while trusting that they were produced in a way which addresses a lot of the problems that motivate the book. And so in some sense, just like all of the particular suggestions that I give in the book are the kinds of things that should be taken into account when producing guidelines. So, I mean, there's just so many of these, but for example, one is, using less biased methods, appealing to different kinds of sciences, including mechanistic knowledge of pathophysiology, when reporting clinical data, using absolute measures of effectiveness rather than relative measures of effectiveness, doing all we can to mitigate publication bias. And there's the point about independent testing. So testing of interventions should be independent of the manufacturing of the interventions. All of these kinds of particular changes to the medical research landscape would lead to better guidelines, and better guidelines are going to be good for busy physicians, and in some kind of like convoluted sense will contribute to patient autonomy, because patient autonomy is a murky thing, as you note. They have to rely on expertise. They can't know what the physician knows. That's the whole point of having the physician as an expert. But when they rely on expertise, they need to do it in good faith. They need to know that the expertise that they're relying on is truth conducive and is something that's going to reliably help improve their health. And so all of those particular changes to the medical research landscape that I kind of trace throughout the book are positive changes that I would encourage.
Yeah. So would you say there are any, presently, are there any resources like that available which are trying to be more stringent in their criteria, those guidelines?
When you say resources, do you mean like institutions or research groups that are trying to do this kind of thing?
Yeah, or guidelines itself. Are anyone? Is anyone producing guidelines like that? Based on those stringent criteria, for example.
Unfortunately, no. So in the ideal world, I think what we would have is like a regulatory body, like something like the FDA in America, which had strong authority and was drawing on the full range of available evidence that pertained to the interventions, and was like completely independent of industrial influence. That would be the ideal situation. There are some research groups here and some research groups there that are making steps in the right direction. So for example, there's this website called thennt.com. So as you probably know, NNT is number needed to treat. It's like just this term for this particular outcome measure. And it's one of the very best outcome measures that can be used to assess medical interventions. And this group is basically doing meta-analyses, or they're drawing on other people's meta-analyses and reporting in a just kind of transparent way that the number needed to treat for a particular intervention. And so that's a step in the right direction. Of course, there's the Cochrane collaboration, which is one of the most important communities of researchers in evidence-based medicine. And there's been a lot of controversy with the Cochrane collaboration lately, but in some sense, they're trying to do the right thing. They're trying to amalgamate evidence, the very best evidence that pertains to particular medical interventions. They focus on RCTs, so they leave out a lot of different kinds of evidence that can be relevant for a medical intervention. And the primary evidence base that the Cochrane collaboration has available to them is just the evidence base which is produced by industry. And so, something like 80% of all medical research resources are controlled by industry. The vast majority of clinical trials are performed by industry. So although the Cochrane collaboration is doing the right thing, it's like, well, in some sense, we're taking a step towards doing the right thing. they're still highly limited in what they can accomplish, given the current landscape of medical research. So yeah, there are people kind of making steps. There are institutions and organizations making steps towards these positive changes. Medical journals are another kind of venue in which like positive change can happen. For example, the British Medical Journal has for many years been kind of activist when it comes to raising awareness about many of the problems. The same with the New England Journal of Medicine, kind of activists when it comes to raising awareness about these problems in medical research. And so, yeah, some institutions are taking the right steps, but as far as I'm aware, I mean, the ideal situation would be a strong-armed regulator employing all of these steps, including having like less biased trials on which to make their decisions, and that just doesn't exist.
Yeah. Okay, I suppose we can wrap this up now. Thank you for your time and for engaging with me. It's been
sure. Thanks for inviting me to have the conversation. Yeah.
Thank you.
So,
right. Yeah, I mean, of course, there are still so many questions, but we'll just wrap this up at this point now.
Yeah, sure. We can perhaps consider having a future discussion at some point. Yeah.
Definitely. Thank you again.
All right. Yeah. Bye-bye.
Bye-bye.